right. I am rolling solo on this pod. Nikhil's busy enlightening everybody on healthcare 101 and all the inner workings of it. But we're going into ops like 205. And in this episode, I'm joined by Rahul, who is the COO of Medplum. He's also a fellow nerd and operator, but in addition to how he thinks through problems is that he comes from the software development world as an engineer. So we've got like this engineer turned operator coming in, and he has seen a ton of builds of EHRs. Now he's working on an EHR itself, but this episode is all about helping you see around corners at different stages of growth and things you can tactically do today as you're scaling through the early stages all the way through like mega hyperscale to make sure that your systems, like on the back end and the way you're thinking through operational decision making, is sound and sets you up for scale. So this is going to be a fun one, a little bit different of an episode where we'll be learning Rahul's playbook. We'll also be getting into how you can scale through all 50 states, which I think so many different companies are trying to get through. And of course, we'll top off with an experiment section for everyone. So Rahul, thank you for being on the podcast today.
I'm excited to be here.
How you feeling?
I'm great. I'm nervous, but I'm excited to share what I can.
Tell us a little bit about this playbook that you've written up and why you think it's important and who's going to benefit from learning all about this playbook.
Yeah. So at Medplum, like you said, we make headless EHR platform. And as such, I've had the benefit of working with a lot of digital health companies kind of on their journey from startup to scale up to serving tens of thousands, hundreds of thousands of patients. In the course of just working with people, we saw some common patterns. We saw how even though everyone is tackling a different clinical niche, some people are doing pediatric mental health, some folks are doing men's health online, some folks are doing maternal fetal medicine. Really, there's surprisingly common set of challenges that everyone faces in the scaling and operations side of the business. So as we work with customers, we've developed this mental playbook. I want to share that with your audience.
What are like the fundamental building blocks of this playbook, or like what are those common problems that you've seen?
The way I broke down this playbook is by stage. I call it the digital health hero's journey, right? You're starting off in the jungle. You're trying to learn about your patients. You're passionate about a space, and then you're moving all the way up to like the grand finale. If you got a 50 state, 2 million patient practice, and you're in employee benefits programs, you're in value-based care, you're billing Medicaid and Medicare, not just cash pay for a certain patient population. That's kind of the bookends of where we want to go.
All right, let's zoom in then on the jungle stage.
Yeah.
Let's go there.
So you get dropped off, you're in the middle of the jungle, you're like, I really care about this problem. Let's take, for example, last trimester, the third and fourth trimester health, maternal health, for example. Third trimester is what we call before the baby's delivered. Fourth trimester, first month of life. This is an important problem. It's underserved, and you want to support your patients through that. At this point, you're optimizing on learning about the patient population, what kind of things you can actually serve digitally, what the mix of in-person, digital, synchronous, asynchronous care is. This is very specific to your company. My playbook at this stage doesn't have a lot, except for one specific piece of guidance, which is to familiarize yourself with the standard terminology that the health system uses. And when I say terminology here, I'm not just saying like the lingo or the jargon. I'm specifically talking about like the way different practices interact with each other via code systems, ICD-10, CPT, NDC for drugs. These it's alphabet soup, but really the point of this is not something you want to reinvent the wheel on here. And if you start thinking in these dimensions up front, you're not going to have to redo it when you have thousands of patients.
This one to me in a way seems obvious only because I come from like a very deep medical device background where codes like ruled my undergraduate education. But I know folks have sometimes, right, they start with the problem and then they sort of try to backtrack into codes that exist and or start cash pay. And then later on realize there was no formal infrastructure of coding. I guess like in your world and in mine, as I interpret this, is that the point of this exercise is like know where you're going to plug into and make money over time and whether there is an existing revenue stream for you to tap into?
Exactly. Like right now, you'll probably be doing cash pay. So it's not really about billing, but it's about just like learning to speak that language, building that muscle in your company of like, when I offer a new service line, like I should go look up what the codes are. Like medical billing and medical coding is complicated. You can get a 2-year associate's degree in actually just medical billing and coding, which is about how do you associate what you did. You're not going to get it right on the first try. And even the definition of right changes as health payers change their reimbursements and stuff. It's really about not getting in the what we call the bad habit of making up your own things. You can either say if someone came in for a rash or they came in for like, I'm making up a code here. Sorry. 1-3 red spot on the building that practice of specificity. Again, my playbook here, we're not at scale right now. We're at learning about our patients, but this is one core element that I want people to roll into their learning.
Tactically, beyond diagnostic codes, what other billing lingo or general lingo should you be keeping an eye out at that stage?
Diagnostic codes was ICD-10. Procedure codes, which is CPT. There's a lot of different kind of codes out there, but in the US, when you get to billing, you're going to need CPT anyway. For most people starting off, it'll probably just be the visit code, so 99215, which is like a 45-minute visit. It's not rocket science, and they're pretty general purpose there. And then drugs, if you're prescribing, and LOINC for if you're doing labs.
So take us to the next step in the journey, the hero's journey of leaving the jungle. What does that look like? Who's there?
So this is leaving the jungle. You're starting to see some signs of product market fit. Which services, which care models resonate with patients? Maybe you've dropped some things that you thought were going to work, but then maybe beyond your chief medical officer, you've started to hire some other clinicians, an MD, maybe some nurse practitioners and stuff too. Like it's starting to feel like a real practice, not just like one doctor and some entrepreneurs doing something together.
Shit is like starting to go on fire, so you know something's working because like something's breaking. All right.
Exactly. And this is probably the time you're like, oh, we should build an app. Like,
red flag, no.
Like spreadsheets, it's just getting a little harder, and we can't just do everything like super manually, or we need run books, right? We can't just like know the right thing to do in their head. This is kind of where we're at here. Where
Playbookizing.
Yeah. And in that part, I think the big thing I've seen some folks get upside down is, okay, I mentioned the app is kind of a joke, but really it's like, oh, okay, patients love us and they love our little mobile app where instead of using MyChart or just phone call system, they can just do everything digitally. But my big kind of announcement to them is the app is not the product. The app is a service to your product. The product is the operation itself. That patient care, the turnaround time with getting an appointment, the level of follow-up that people get, that is the actual product you're selling. The app is just an enabler, just like the EHR is an enabler. All these things are just tools for that patient experience.
Do people just get really excited from like a product perspective or like a marketing perspective around just like the facade of it and what it delivers versus they under invest in the ops side of it? Is that kind of the overarching thing you see?
Yeah, I think, the brand is important, but we see a lot of folks get like turned upside down on the brand, especially because some of this stuff is very consumer facing, right? Like you're saying,
For sure.
I'm focusing on this very specific clinical niche, cash pay. So I'm basically in a consumer business. My brand is how I stand out.
Mm.
But brand is a very all encompassing idea. People can get locked into like, how does it look? What is the number of clicks? Which are important things. But these are all in service of the end-to-end patient experience between when they find you and when they get care.
Yeah. So what is the ops playbook for behind the scenes, making sure you're executing right there?
So your spreadsheet process is going to start getting messy, right? You got more patients you can keep track of. You've got people who weren't in your founding team that need to know to do the right thing and not have stuff fall through the cracks. Kind of my key piece of advice here is one, start figuring out your care models, the head versus the long tail of what you offer. With clinicians, you can't tell them necessarily like you only diagnose these two things coming out of a patient visit, right? They're going to diagnose what they see. You can't say like, oh, only prescribe these two drugs, especially in something like, I'll go back to like pediatrics as an example, right? It's like whatever the kid needs, you're going to have to prescribe it. But you kind of want to know what is like your 90th percentile of reasons people are coming to you and really like consolidate that versus and then leave the long tail open but just put it in the other category. So I'll give some examples there. One of our customers, Summer Health, they're a fantastic team. I think you had them on the pod as well. Yep. And they do, and I'm also a customer of them as they are also a customer of me. Love their service. So they are for non-acute, non-emergency pediatric care over text. I can text them anytime and say, my daughter's eyes got puffy. Does she have an egg allergy? Can you prescribe an EpiPen? I've actually done that. Real world example. But they kind of know 80% of the things that are going to see across the door are a rash. Pink eye is like a common one. So just like they make that its own category. Fever, cough, a couple other things. They optimize around those. And they have another category too of like other reasons people come through the door, but they optimize their service offering around those common things. So at this stage, it's like we're going to figure out what are the main reasons people come through the door. This is like our service menu so that we can then put it on rails. We can say like, what's the standard playbook for runny nose for everyone? It's going to serve us better in that next stage when we're dealing with thousands of patients and like a team of clinicians that doesn't even know each other. Like they're just logging in. But this is a stage where you have the leeway to actually do the analytics and to know your customers. Another one is we have a customer that does at-home diagnostics for men's health. They don't do like 100 different blood tests. They do 2 or 3, a testosterone, a metabolic panel, a couple other things in service of their downstream things. And because of that, they can optimize their processes around like, if it's a testosterone panel, these 3 things need to make sure that they always happen. Like it's this visit, that is the follow-up, this is the interval of when we do a referral or when we do a check-in, things like that. If you have 100 different items in your service menu, everyone's kind of an artist, and you'll not get consistency across your clinician population, and your patients aren't guaranteed to get the same experience when they sign up.
And so this is like pretty much brute force around seeing what is the 90% and then behind the scenes getting abundantly clear on those, let's say 5 ICD-10 codes and mapping out behind the scenes, like everything from like encounter all the way through finishing up that encounter, and super clear what needs to be documented, what intervals do we have to follow up in, what is the care protocol, and so on. And that's sort of the recommendation there.
Yeah, exactly. So I would say like you can look at what your clinicians are documenting now at this stage and just like tabulate them, do like group by count. What are the ICD-10 codes that they are doing, and see where there's like potential overlap. Are some doing 30-minute visits and some doing 45-minute visits? Maybe let's just like combine them. We're all just doing the 45-minute visit.
Oh, got it. Yeah.
Because like if you go into the straight analytics, sometimes you'll see like, oh shoot, there's 100 different codes. But like if people are all just making their own judgments, a lot of them talk to the same underlying problem. We just made slightly different choices. So what I'm talking about here is just try to consolidate it. So it's not just about doing less for your patients. It's really about consolidating what you're doing and try to find the boundaries there. Tactically, look at everything something's billing, group by count it, figure out how many things are in the 90th percentile. If you just sort by most common, you want to target up to 10. If you're like, obviously if you're 11, I'm not going to give you a hard time. If you're like 20,
who's going to find you if you have 11 service menu items?
I know where you live. I'm using the HIEs to find you. Just kidding. But yeah, if you've got like 20, like try to find where those are. Or, you can come back and tell me like, we have 20 conditions that we treat. This is core to our business. This is what we do. And that's fine. It's really about just knowing and doing that intentionally rather than everyone's kind of doing their own thing because we weren't looking.
The following message is brought to you by Out of Pocket. People who have been tasked with building a call center have many questions. How did I get this job? What are my options? How will this affect my loved ones? Will I ever be happy again? You need answers. That's why we made a course led by call center veterans who've been there and recovered. Join nearly 100 others who have not learned the hard way. To enroll, call toll-free today to reach no one, or go to outofpocket.health. Hear from Stephen, a student who said, quote, "This course was hugely validating and packed in many invaluable insights that we would have otherwise had to learn the hard way. 5 out of 5 stars. You can be Stephen. Save money. Start learning. Enroll today. For $100 off your seat. Use code ANSWERS. That's code ANSWERS for $100 off."
This episode of Ops, I Did It Again is brought to you by me, because no one believes in me more than me. I'm teaching a Healthcare 101 crash course that starts soon, You can find it on the Out of Pocket website at outofpocket.health. We go over all the major stakeholders in healthcare, payers, providers, pharmacy, all those in between acronyms that you've been too scared to ask people what they mean. We talk about how the money flows, major laws in the industry. It's the fastest way to get up to speed on US healthcare. You can use the code I believe in me to get $100 off.
Are there other guidance points before we jump into the big scale?
Yes. The other big one is figuring out what is an encounter for you. You know, in the beginning, when we were in the jungle, we're just trying to treat people. We haven't defined the clear boundaries of like, this was one encounter, this was another. Maybe I called this patient 3 times today because I forgot to ask him a question. Whatever, that's fine. Now we're starting to get a little bit more formal. And especially in digital health models, it can be hard to define what is one encounter versus 2. Like if you and I are just texting and I go to sleep and then I continue the text thread in the morning, when did that encounter start and stop? In legacy healthcare, when you're walking into the 4 walls of a clinic, an encounter is very easy. It's like when you walked in and when you walked out. The rest of the healthcare ecosystem still works around that model. It's like, you bill per encounter. You kind of aggregate counters into what we call a case or an episode of care. There's kind of analytics on an encounter, like how long did the encounter take? How many encounters did it take to get to a certain health outcome? And it can be hard to map those to the digital world.
Yeah, in my head, it's like the pretty picture of door in and door out. And then that's on the left, and on the right is this maze where it has the home and then your office and everything in between, which is where the digital health world lives. And so what's the start and what's the stop there?
The whole point of doing this was that you don't have to go into the clinic.
True.
You don't have to walk in, walk
Right.
out. So we are generally adverse to putting these artificial boundaries on things. Mm-hmm. But my point here is you got to learn how to talk like the rest of the US healthcare system. You're going to have a much easier time if you've made some decisions around this. Even if they're not perfect, just being able to package your interactions and being able to share that with your paying partners when you do analytics and clinical quality management, say you're getting certain certifications like CLIA or something like that, knowing where these encounters were, being able to tie things to that. For instance, was this diagnosis made during a certain encounter? Which encounter was this diagnosis made where I identified that Rahul has an allergy to pistachios?
There are a lot of allergies going on in your home. There's eggs and pistachios.
It's on my mind. My daughter's at the age, there was this landmark study for allergens where they said, if you introduce allergens to 6-month-olds, they are much less likely to be allergic to that thing late in life. So now all the yuppie parents are just loading up all their kids with peanut butters, tree nuts. They actually make these powders, which is all the allergens that you just sprinkle into their oatmeal. So my daughter's 8 months and we're just hardcore on the allergy. We're just putting everything into her.
Got it.
We're not even feeding her. We're just mainlining her allergenic foods.
How's she doing?
She's doing fine, but we did discover she had an egg allergy, which triggered some of those other things that I was alluding to.
Right. That's what you were texting.
That's why I was texting. Summer Health had my back. It's also kind of scary because until you know they're not allergic, the next thing you introduce, they could go into anaphylactic shock. So you're
true.
Hopefully this is okay.
Yeah, that's terrifying. What would be the encounter? Let's do that one as an example then. What was the encounter start and what was the encounter end of the
That's great.
Of the egg allergy saga?
I worked with Summer Health on this when they were designing their system.
You're answer me faster.
Well, no. Well, if I may answer, there's bad, okay, and the ideal way of doing it. Yeah.
All right.
The bad way is doing it, you just don't have encounters. And because I'm texting them, right? So we just have one text thread between me and Summer Health. That's how it looks on my phone.
That's me and Nikhil's level of how much we measure our encounters. Just long ass text threads about everything.
It's just one big glorious encounter.
Yeah.
Strong advice not to do that. And that was one thing. It's it wasn't obvious when we started working together. It's oh, we need to break this up. The okay way to do it is to use some kind of time-based rule. Patient has responded in 2 hours. The encounter is over. Next time they text me, that's a new encounter. Great. It's passable. We've talked about what happens if they go to sleep. It's you're going to be time zone aware. Whose time zone is it? Is it the clinician's time zone? Is it the patient's time zone? Is it both? Because one of them might be asleep at any time. What if they were dealing with the actual anaphylactic shock and they just didn't have time to text? So it's something, but it's not the ideal. The ideal is actually you just give the physician control. You say I am starting an encounter now, and I'm not closing it out until I feel like this has been resolved, which kind of feels like a step backwards sometimes. We're hey, this is manual. But in our experience, we found that there's no automated rule that isn't either crazy complicated and you're using like, I don't even think ChatGPT can like get enough nuance on this to like know like we're not talking about a different thing. Also, people interleave conversations. I might start a new thing with Summer Health about a different thing and then circle back to the old thing. So it's really using the clinician's judgment of like, we are done talking about this topic. I'm closing out this encounter and I'm like going to write up the note for it. That's the way to do it.
Do you ever run into like forgetting though, if it's
Yeah.
too long? So what do you
Yeah.
do in that case?
You ping both. So like, are you done? And eventually, even with Summer Health, clinicians will close it if I haven't responded in a while. But it's like, is their judgment, and they've decided we've come to a resolution, or they can choose, hey, like this was not resolved. Can I keep helping you? And they will kind of keep reaching out to me rather than it just being an automated thing.
Does that happen often where things just stay open?
It does, especially at scale. When you're managing like 100 clinicians or someone, like at some point, someone will have forgotten to close it. And that there are definitely nudges like, hey, this has been open for over a day. This goes back to if you go to your previous step of like knowing yourself and knowing what you do. Hey, we typically have 45-minute kind of interactions, even if it's text-based, versus like oncology, like maybe we're actually encountering like kind of talking for hours at a time.
Yeah.
Another customer of ours, Imagine Pediatrics, but they're very different. They focus on really high risk kids with like either terminal problems or very severe life altering conditions. And they provide tiered support of they can have clinicians chat with the parents. They can have like folks come in for an emergency intervention and send like their clinicians to your house and things like that. But they would probably have longer encounters because these are more confusing, more acute issues. And it might be like, hey, can you stay on the line? Like the parents are about to try something and then they'll report back. So I can't say one size fits all, like this is the time for the nudge, but if you've identified what your typical encounter looks like, you can tailor your time-based nudges rather than having it be a hard rule to close the encounter. You can use those timers to define your nudges. And then usually the other nudge you have is a human nudge at like a supervisory level. Maybe you have like a senior, like a clinical advisor that handles all the California clinicians, giving them a dashboard. It's like, hey, these people still have encounters that have been open for like 5 days. Like maybe you should like check in with them. So like the automated nudges as well as surfacing it up to the next level of supervisor can be helpful.
Does the playbook of a physician owning the decision on the encounter ever not work?
Probably.
Or the provider. Sorry, I meant to say generally, but you get what I mean.
Yeah. There's kind of different levels of not work. Is like, do they close it too early and then sometimes the patient will check in again? Yeah, that'll happen.
Then what do you do in that case?
You can give them tools to like reopen it. You can also just say, hey, this is a new encounter that's a follow-up to that encounter. There's nothing perfect. And like, I don't want to say this is a silver bullet to anything, but it is much better than not having a notion of encounters, especially in the asynchronous case. Like with synchronous, even if you're telemedicine, it's like pretty easy. Like we're going to record this podcast. The encounter was the start, the end of it. The other thing that kind of having this encounter breakdown helps you with is who was participating, especially in the case where you're doing caregivers. So we're working with another company, Scene Health, where they do geriatrics. So adult children helping their parents. So it's like, who actually showed up to this? Was it just the geriatric patient? Was the patient and a family member? Oftentimes there's coordination of multiple caregivers. It's not like with parents, it's parents and child.
Yeah, we ran into that a lot in DME.
Right. It's like maybe multiple siblings are coordinating care for their parents.
Right.
So different people showed up. And that's all relevant information when you're thinking about like the concierge patient experience isn't just for that adult patient, is for their caregivers. It's about making sure they have all the information about the health of the patient. It's important in the case of knowing who was not present in certain things, like who may be missing information. When did that encounter start and stop?
Okay, got it. All right, let's go. I'm ready for next stage. Sounds juicy.
Right. You have 100,000 patients, and you're also getting to a point where you're hiring more MDs, nurse practitioners, care navigators, all these people to handle the load. And now they're slotting into a system. They're no longer like all friends with each other, not always on the same meetings. You're realizing, oh, shoot, MDs are expensive. They have a day job that you're competing with here. And they're also pretty particular about how they want to do certain things. This is usually the point where it's harder to provide the same level of care that you got for free when you were in the jungle. The jungle was hard. You didn't always know what you were doing, but you were there for your patients. You could pick up the phone 3 times a day because it was you, the founder, you, the CMO. Now you're hiring people who it's a job for them. And it's not that they don't care, but they need to know what the system is. First kind of major tip here is like, let's develop some care plans, also known as protocols, also known as clinical pathways. We all kind of use different terms for this. Basically, we're going to say, of the services we offer, we're going to take that 90%, the head of your distribution, and we're going to put it on rails in terms of building checklists so that an MD knows when they come in, just hired off the street, they know like the row way of doing it. For each kind of step in the checklist, you want to know who's doing it. Is it the patient? Is it the provider? And if it's the provider, who? Is it a care navigator, customer service, someone with a nurse level credential, or like an MD? What is the task that they are responsible for? And are there any timing elements here? Like, does it need to get done within a certain amount of time? Or does it need to get done within a certain amount of time of the last thing? So the kinds of things that will go on the checklist are fill out this form, schedule this appointment, like have the appointment, write the note, send lab results or something to the patient, verify their identity, verify their insurance. It's like all pretty tactical things that like it's in our heads, but like every single part just needs to be written down. And you want to get the timing of like, okay, we always want to follow up visit at least between 2 to 3 weeks after the last one. And this is kind of where I advise folks to make a flow chart of the process for each of these kind of pathways. So each node in this flow chart is going to be one of these steps. It's going to say who's going to do the thing, what is the thing that needs to be done, and kind of how long do they have to do it, and like when does it have to happen in relation to the last step in the flow chart. Because the next thing we're going to talk about is top of license care. Basically, every task you want to be done by the person with the lowest credential who can do it. Basically, it's a big buzzword in hospital administration in general. My wife's actually an MD, and I remember when she was in residency, everyone was really focused on this buzzword, top of license care. The idea is you as a clinician are only doing things that your license requires you to do. If there's something with someone with a lower credential could do, they should be doing it, because it's supposed to be the most efficient allocation of time resources. And time is your scarcest resource across all these folks. As an entrepreneur, it also will feed into your headcount resources. MDs are much more expensive than customer service representatives, which are much more expensive than a bot or something automated. And so you want to build your pyramid of do as much as you can automated, and then as much as you can by customer service folks. And you want your MDs to be probably the fewest, but the most efficient members of your team. That's also how you'll scale in terms of having the best customer experience, still providing quality medical care. I break down to 4 levels of licensure that you want to allocate across in this pyramid. One is stuff that's automatable, like a computer can do it. It doesn't even have to be a human. No judgment calls. For example, sending a welcome email when someone signs up for your service, right? It doesn't have to be a human. Maybe in your discipline, there's like something about the way you want to provide care that you want to be like a person. I'm not going to say that's wrong, but it doesn't have to be a person per se. The next level is it should be a human, but not someone who with any kind of license. For example, like asking a question about their billing settings on my account, or maybe following up on an insurance question, which might like require some level of training and knowledge. Like they might need to know how to navigate the healthcare system. They don't need a certification that proves that. So I'm not saying these people are unskilled or unspecialized, but there's more supply because they don't have a certification requirement to do that kind of job. Next level is the clinical folks that are non-MDs. And I don't mean to be elitist here. It's a different kind of certification, a different supply profile. And there's a spectrum in here, but that's kind of your 4 levels: automated, no license, clinical, non-MD, and then your MDs. And you always want to drive all these tasks that you did in your flow chart to the lowest level as possible. So you don't want your MDs checking driver's licenses or doing the insurance confirmation. In traditional healthcare practice, if we map your front desk people there are not just answering calls, they're often doing a lot of this insurance checking and kind of admin work.
So the flow chart is really holistic of the entire patient experience. It's not like encounter-based flow chart. This is literally of what happens when the moment somebody comes in all the way to whatever the end state is of your business.
Yeah. And so the boundaries of it are like, yeah, patient signs up to like patient receives care. And then there might be a little loop in there. As you know, we have an ongoing monthly check-in or something. It should be across, like I gave the suggestion of you have like 5 clinical pathways or 5 care plans mapping to your 5 to 10 elements of your service menu, the 5 to 10 diagnoses that people come in for.
Oh, interesting. Yeah.
So that's why we did that in the last step. It's like, what are people coming in the front door for? Now we're here, we need to get that intake all into like a kind of a railroad process, which will have exit ramps. This flowchart should be your happy path. Now, it's not going to encompass every single thing that might come up. That medicine doesn't work like that, but you at least want to document your happy path, because then across your 5 pathways, you'll see like, okay, we have to do an insurance check for all of them, so they should converge there. The point of like kind of doing this holistic thing is you'll see what tasks are in common, who's doing them, and therefore you can say like, is the right person doing them, or do we move it down the pyramid? And then where are the bottlenecks? Like this step is starting to take a long time. Like it should take 45 minutes to do this. In reality, it's taking someone on average 3 hours. What can we do to address that?
All right. So guidance around checklisting and flow charting, and then kind of being really nuanced within each one of those nodes. What else do you suggest folks do here?
So now we get a couple more unlocks now that we've done the work of knowing what our service menu is, knowing what our care plans are, is you can actually simplify the provider inputs. And so this is kind of my EHR nerd coming out, but a lot of these digital health companies live and die on their EHR admin setup, because you got to recruit clinicians at the end of the day. And you talk to any clinician, their least favorite part of the job is charting and like inputting. Like they love seeing patients, they love taking care of people, they hate all the paperwork that goes along with it. I've known, I can't mention by name, but I know digital health companies who are losing clinicians because they were too frustrated with the system they'd kind of cobbled together. And I also know, I think Summer Health, they told me that they built something that physicians loved. They were actually able to convert some people from contractors to full time because it was so streamlined for them. The bar you're trying to beat is whatever their day job is. Some examples we saw there is like Summer Health. We always mention they knew what their service menu was when they're charting an encounter. You got 6 big buttons you can use with your thumbs. Came in for a rash, red eye, things like that, like simplifying the amount of typing, fewer drop downs, more buttons, all of these things just streamline the thing along. The more you can do for that. Also, pre-population is a big thing. So I got 2 examples. One is a pediatric EHR that was built on top of Medplum called Develo. They know that in pediatrics, when insurance claims get denied, usually it's not because of an argument about medical necessity. It's usually an argument about, was the paperwork filled in properly? So given that they know their service menu, they can have really rigorous implements about like just making sure all the right data is pre-populated. You don't have to retype in the patient's name every time when you're charting an encounter. You can just pull all that there. So it's less error prone, takes less time, and you're going to get less denials at the end of the day.
My takeaway in the idea of designing better EHRs or better physician workload is all around reducing the cognitive load and coming back to like maximizing time and maximizing correct throughput. If you work on both of those, you actually just make a better product experience for everybody. Yeah. Okay. That makes a lot of sense.
Yeah. And I do want to emphasize the recruiting aspect too, because your ability to service patients will be related to what your capacity is from a physician staffing level, and your ability to recruit physicians will impact how many physicians you have to service your patients. Last thing, we already talked about identifying your bottlenecks. This is also, we talk about tracking your quality. What's your turnaround time to get an answer to a patient? How many times are people not following the protocol, or is like a certain follow-up not happening, things like that. People do this generally. It's not a thing that is a blind spot at this scale, but my big push to folks is start off with the well-known metrics that everyone else cares about. So like HEDIS or CMS measures or risk adjustment factors for value-based care. People sometimes go wild with like metric soup. Like every business unit, like the product team wants one set of business metrics, business development team wants one set of metrics, the clinical staff and the MDs want a different set of metrics, and then you have like 50 metrics and they're all different shades of the same color. If you align around some of these standard ones, like HEDIS is a big one for performance-based reimbursement from payers. Not that everything is about payers, but it's a thing that other people are going to report anyway. So you might as well start there, see what it doesn't address for your organization, then augment them. Rather, than starting from whole cloth and then having to like kind of wedge your metrics into these standards that eventually you're going to report. So HEDIS, CMS measures, and then risk adjustment factors for value-based care.
How many, like, is there like a special number you've seen be a good amount of clinical measures or
Start with
anything like that?
5.
Or
You'll probably
not
get pushed.
6.
You'll probably get pushed to 10. I think there's always upward pressure on these, or like some teams like not getting quite the visibility they want from your initial
Yeah,
5.
of course.
So I'd say if you aim for 5, you'll end up with 10.
Love them. Awesome. Okay. Do you want to add anything else to like the moon or this stage of growth?
I mean, this is the fun stage because it feels like you're onto something and patients like you, but it also can be incredibly frustrating because it starts to feel like the wheels are coming off sometimes. Where it's like, this is the stuff we used to get for free. Like our patients never complained. Now we're getting some complaints. Now, and I want to help you get ahead of that.
100%.
And it's not that this is going to fix everything, but it'll get you, I use the term a lot, fighting fit. It'll get you to have good hygiene so you'll be in a good place to fix the things you need to fix.
After the moon phase, is there any other phase afterwards?
Typically, these kind of go hand in hand, but I just broke it out as going 50 state. Sometimes you can get a big patient population across like your first 3 states, New York, California, Washington State, something like that, a loyal following there. Now, when you're really spreading out geographically, it's exciting, but there's just a couple more challenges that come along with it. And the biggest ones is licensure, making sure when you had 15 MDs, you were feeling good because they were hyper efficient, but they're not licensed in all 50 states. Like, who's going to cover Mississippi? And so there's just an extra level of organization that I want you all to add on top of that. And my big push here is like, try to organize your practices kind of like a physical hospital, just virtual, which oxymoronic, but what I mean there is don't try to get cute with terms. Call a group of specialties a department or a ward. That's what your clinicians are familiar with. Don't call them like a
Think boy team.
Think boy team. I'm trying to think like a battalion,
Yeah. Or like the onco care team, or like some abbreviated thing that you think is like branded internally some way.
Yeah. It's tempting, but it's just like, again, you're hiring folks who don't know your company that well. Again, this might be their side job. So having them have that mental model of this is how I slot in. I got a couple do's and don'ts here. So do call them department, ward, institute, kind of map it to a general hospital, and then do organize along 2 axes. One is the department or specialty that people are working in. So like your OBs versus your allergists versus endocrinologists, whatever. And geography is the second one. Where are they licensed? Where are they allowed to practice? Don't organize them along your product offerings, which is a common mistake I see. It's like maybe within gynecology, I offer STDs, birth control, and a couple other things. Those are customer facing products, but they're not how you should organize your clinical teams. There's going to be foreseen but unplanned circumstances, like your doctor's going to go on vacation. You might need someone on call at weird hours. Someone might be sick. We had, big practice work with us. They had 1 million patients, 50 state practice. They had multiple different service lines, but they'd mapped everything really along their user-facing products, partially because they had grown through acquisition. So they used to be all different companies. We kind of went through a process with them to like, let's map this to like how we would look at a physical hospital, so departments, and then they had a leaf node there, which is like care pods, like really tight teams of a couple nurses, 1 doctor, all work together. That's great. And then we map those care pods to like what geographies can they cover. Like this care pod can cover these states. And then we could see like the heat map of like which states have high coverage, low coverage. And they had a written process as a flowchart, but like they just did it as bullets of like, if someone is out, what is the search process to find their replacement? Like first look in their care pod, then look in their department for someone of the same credential with the same license. Then like go across to a different one.
On our episode with Nate, he also broke down the pod structure around complex care management and geographical alignment of that. So that's something that we've heard before too, the importance of geography and pods.
Yeah. Again, it's about understanding, having clinicians kind of just slot in and not having it be a huge cognitive load for them of, okay, in my day job, I do this, but in digital health company A, this is how I think about my job.
Keep it simple.
Talk like the healthcare system.
talk like the healthcare system. All comes back to that. All right, Rahul, we're getting to the end of our time, but we like to end every podcast episode. Recently, this is a new experiment with 3 experiments folks should try inside of their org. So what are three experiments you want to encourage folks to try out in their orgs? Ideally, they've worked for you before.
Yeah. The first one is do a ride along with a clinician for a single patient's journey, like from patient intake to care delivery. Like just do a ride along and see what are the bottlenecks, what are the things that they maybe haven't complained about, but you're like, oh, why are you doing that? In terms of like data entry, something like that. It's like, oh, like that kind of sucks. Big kind of things to look out for there is like, are they typing in redundant information? This sounds silly, but it's frustrating and also it's error prone. The cost of fixing a mistake if they mistype a patient's name or if they have an off by 1 error on a date of birth, it's a huge remediation process once the toothpaste is out of the tube. So figuring out, does that happen? How often does that happen? Also look at how many tabs they have open. Oftentimes these clinicians to do their jobs, they're logged in a few different systems. Maybe they have like their own like notes, like in a Word doc somewhere. And it's like just understanding like how many things they need to do to get all the information for one patient care journey end to end will be pretty insightful in terms of understanding, building that flow chart that I mentioned.
I call it Tab City in my
There you go.
course. Happens to everybody in the startup, but yeah, anybody delivering care. Definitely clinicians though.
And then it's like, do you get the extension that manages your tabs or do you enforce discipline of like, I'm just going to close things?
Only time tells. I don't know. I don't have a good answer for that.
I've avoided the tab thing. I was like, I'm trying to go the discipline route. We'll see how it goes. The next experiment I'll say is like, list all the tasks for a single care plan. This is related, but like once you've done that ride along, like take one of your care plans, just write down all the tasks that you said. Who did it? Who does it? How long should it take from the last thing that they did? Or like kind of what's the timing constraints there? And then ask like, is everyone working top of license on all that task? Just for one care journey, one thing that your company does. Is there anything automatable? Anything that can be pushed to a lower license? Last thing is just like take stock of your service menu. The first two were kind of narrow, one care journey, one patient. This one's more broad, like collect all the ICD or CPD codes that you're performing right now. Just do a group by count. Look at the distribution. What like how tight is your head and how long is your tail? Like if you do your 90th percentile, is that 5 codes? Is that 50 codes? And then look, first thing is like, look, is there anything that be deduplicated? Or is there anything in the head that's surprising? It's like, oh, I didn't know we were doing that. I didn't know we were treating this. And see if you can find at least some opportunities to bring it closer to that like 5 to 10 marker. Or like have a reasoned thesis on why we do 50.
It's a lot, 50. Yeesh. Man, people surprise me every day. Rahul, this was awesome. This was super, super tactical. I learned a whole lot about how to think through and orchestrate a lot of change in very simple ways. And I know folks are going to gain a lot out of this episode. So thank you for distilling your wisdom built through the many years of seeing lots of builds so that others can benefit from it. So that's the point of the pod. And we're grateful that you got to share all this today. Thank you.
I'm grateful to have been on it. Thank you.
Awesome.